Thank you so much. Good morning, everybody. It's you all made it. Construction time is here, and the rain's eased off, and the weather is beautiful. So it's really good to see all of you in the room. I'm Rahul Karane. I have the privilege of serving as the president and CEO of the Minnesota Hospital Association. Before I turn to our panelists, I'm just going to make a couple of opening comments, and then I'll moderate the panel so you can hear from leaders from across the state. We've tried to be very deliberate. One of our leaders from MHA has been on the planning group, so we've tried hard to bring perspectives to you throughout the day from leaders across the state. So you will hear from a Minneapolis metropolitan leader in the closing keynote from Hennepin Healthcare. And to balance that, this morning, we're going to take you on a tour of rural communities across the state. So that you can hear about work that is happening in healthcare across communities where patients always come first. So I am an internal medicine physician. I work and worked in primary care and then in hospital medicine. I was raised in New Delhi, India, and trained in Brooklyn, New York, in a large inner-city hospital, much like Hennepin County Medical Center in the mid-90s. And I've been in the state now working in healthcare for 25 years. And so my remarks, I was thinking this morning about you all and trying to visualize who was going to be in the room and how many of you were going to be in there and what, you were all going to be eating, and the food looks great. So as I was doing my yoga this morning, I was thinking, well, what should I talk about that would be fun? Because life's too short not to have fun. So I think I'm going to turn all physician on you this morning before I turn it over to our panelists to tell you about what their teams do in the communities. But before I turn all physician, I do want to recognize some folks in the room, and I won't call them out because you're going to hear from them later in the agenda, but these are our lawmakers who serve in the state legislature and serve the constituents that are in their district, but also, by definition, serve all of us and all of Minnesota. So we know you're in the room. Thank you so much for doing the panel this afternoon, but thank you for being here to hear our thoughts this morning as well. And thank you for your service at the legislature. Turning physician. So let's talk about healthcare as a patient. What are the symptoms that we see on what is ailing this particular ecosystem, this particular industry? I don't like that term because, when you say industry, you sometimes think of large for-profit corporations, and most of the healthcare organizations in Minnesota are not-for-profit. All three of our leaders here come from not-for-profit community-based organizations. But so let's talk about symptoms that we all as patients see. First is, despite our efforts over the last many years on cutting down our own costs in hospitals and clinics, healthcare remains pretty unaffordable. So affordability is a symptom. And the leaders here and in the room from hospitals and healthcare organizations, this is something we work on 24/7. What are the costs we can cut down? What are the expenses we can cut down? However, there are fixed expenses. For example, we of course need to pay our physicians and our nurses. We of course need to support our workforce. We of course need to buy the latest pharmaceuticals, no matter how high that price has been jacked up. So affordability is a symptom that we all feel. The second is, despite all of our efforts and how hard our physicians and our physician assistants work and our clinic staff work, despite how hard we work in our retail environments and on Zoom and in virtual settings, access is still difficult, because we still have workforce challenges. But we're working on that. But affordability is a symptom we all feel as patients. Access is a symptom we all feel as patients. And financials of the not-for-profit hospitals and healthcare systems are really difficult right now. So that's a symptom that we all feel and see. So if those are the symptoms this patient is presenting to me in my primary care clinic, what are the root causes? And I'll end on that and then turn it over to the panelists. The root causes are the changing demographics of those whom we serve. Our patients are getting older. They are having more chronic illnesses, sometimes 5, 10, 15 of them, and our physicians and our nurses are trying to manage them to the best of their ability. We are seeing much more mental health illnesses and substance use disorders, especially since the pandemic. So we are seeing an older, a sicker population, and that's demographics. You know, we can try to change that, but that is something that is happening to us. We also talk about middlemen. And that's a concept I think you will hear about if you listen carefully. The not-for-profit hospitals are struggling financially, but there's enough money in the system. There are for-profit neighbors a couple of miles down the street from the not-for-profit North Memorial or Hennepin County. Well, you know, our systems, not-for-profit, say we are losing hundreds of millions of dollars, and down the street there's a for-profit corporation that just went up on their quarterly forecast into hundreds of millions and billions of dollars still in the healthcare sector. So there are middlemen like pharma, like for-profit players, like PBMs and others that are siphoning off the money, and it's not getting to us at the very bottom of the funnel. We are the ones touching the patient. So that's something that the lawmakers worry about, I know. Workforce is obviously an issue. We'll talk about that. And then finally, there's a lot of folks here from the Department of Health. You're our partners. We also worry about social determinants or social influencers of health, like housing, like transportation, like obesity, like living situation, education. So all of those things which healthcare system traditionally is not in the best position to try to address, although we are trying to do that. So as I turn to our panelists, we appreciate the public-private partnership that we have with our lawmakers. We've had for the last 108 years that the Hospital Association has been around. The only path forward to reclaim Minnesota's standing in the country as the best state to receive and provide healthcare is by working together with all of you. That's the only reason and the only way we're going to go forward. That is the reason we are here trying to tell you our story, and we plead for continued partnership with our lawmakers, but with all of you. So let's go across the state. We are going to go to an outer ring suburb a little bit. I don't know if that's an okay way to describe where you are, but I will turn it over to Ben.
All right. Thank you, Raul. And thank you for allowing me to be here today. My name is Ben Davis. I'm the president and CEO of Glencoe Regional Health. I'm a father of 3, now I guess a Little League coach. I'm coaching now, so dealing with aging parents. And so, as Raul said, I think today we're going to talk a little bit about workforce, but that's really related to access. And access to care for those that we care for and people in this room. As far as Glencoe Regional Health, we're, again, a 25-bed critical access hospital. We have a 108-bed long-term care facility, as well as a 40-apartment independent living center. And so we serve a community of about 30,000 people just west of here, about an hour. And that community depends on us, not only for their health care, but also their economic development. And so small communities like mine, we depend on each other. We take care of our friends, our families, and our neighbors. And it's important to us that we are able to continue to meet our mission by offering high-quality, safe, and accessible health care. And so today I want to talk a little bit about not only some of the things that have changed or have happened recently in the last couple of years, but also some of the challenges that we face and then the opportunities that are available to us if we work together. So recently, the Minnesota Hospital Association 2024 Workforce Report highlighted that we've been seeing positive trends in workforce recovery, particularly in nursing. For the first time in years, nursing vacancies in hospitals have dropped significantly, with registered nurses returning to the workforce. At Glencoe Regional Health, we've also witnessed this change in retention rates and more staff returning to the bedside after the COVID-19 pandemic. But there are also opportunities. The average salary for a registered nurse in Minnesota reached nearly $95,000 with one of the highest adjusted pay rates in the country. That's something to be proud of. This is encouraging as it shows that we're valuing healthcare workers financially, but we also need to continue investing in workforce retention strategies and building career pathways. On the other hand, we also have some long-term challenges that we're facing. Minnesota's healthcare workforce is aging, with more of our patients falling into older demographics and seeing an increased demand for healthcare. At the same time, fewer younger people are entering the healthcare profession. And right now, fewer than 40% of registered nurses in Minnesota are choosing to work full-time, a figure that has reached an all-time low. This puts significant pressure on staffing models, requiring us to rely more heavily on part-time or per diem staff to fill gaps, which impacts patient care, staffing flexibility, and long-term workforce sustainability. As far as our physician colleagues, I felt that this data point was really impactful. But over the next 5 years, more than 1 in 7 general practice doctors and nearly 1 in 5 specialty physicians in Minnesota will reach retirement age. And so that is a scary statistic for me as we are focused on access and keeping access in our local communities. And so what are the opportunities for us to work together to maintain access, not only for Glencoe Regional Health, but for the state of Minnesota? A sustainable healthcare workforce isn't just about attracting new hires, it's about retaining talented individuals we already have and creating career pathways for career growth. We've seen this, and we've tried to do this in our organization, is providing and creating nursing assistant programs that can directly be involved in our organization. And so support in that area is significant. Getting young people into healthcare careers, that is an access point that I believe, and I think we believe that would be successful in the future. While we continue to make strides throughout Minnesota, we can't do it alone. This is where partnerships such as those we're cultivating with MHA, with other hospitals, and with educational institutions and our local government legislators are very important to what we do long-term to create and sustain our workforce pipeline. So these challenges are complex, certainly, but again, as Raul said, if we work together, we can overcome some of these challenges and maintain access to healthcare in Minnesota. Thank you.
Great. Thank you, Ben. We will now take a tour up north and go to Staples, so I will turn it over to Lisa.
Good morning, everyone. Thank you, Raul. Thank you for having us here today. I do appreciate the opportunity to open up the communication and speak with all of you. As Raul said, I am from Lakewood Health System in Staples, Minnesota, which I'm kind of representing the entire north half of the state, which is a big burden, but Staples is located just over 2 hours northwest of here. It's where my husband and I choose to live, work, and raise our 2 children as well. A beautiful community kind of in Lake Country. Lakewood Health System is an independent system. We are not affiliated with the larger system, a rural healthcare system that provides the whole integrated spectrum of care. We have a primary care foundation, meaning most of our physicians not only see our patients in the clinic, they also cover our ER, they also cover our hospitalist program, and our family practice providers also provide OB coverage. At our facility, located in a town of just over 3,000, last year we delivered 525 babies. So as a community hospital, we are very much committed to a core set of services for our community, ensuring that those services that are so vital for rural areas continue to be provided. Things such as OB care, ER care, ambulance services, long-term care, hospice care, a lot of services that unfortunately don't provide a margin. So we find ourselves in the challenge of finding other service lines, trying to diversify our portfolio, if you will, to bring in service lines that can help to subsidize those critical programs and hopefully get us to break even so we can sustain and continue to provide those within our communities. A little bit about Staples. We do cover 3 of the poorest counties in the state, which leads us to have a payer mix that's about 70 to 75% Medicare and Medicaid. Of those 525 babies, over half of them were on Medicaid. We are a cost-based reimbursed facility. So a lot of people hear cost-based and think, oh, it's break even, that's great. On the surface, that is the case, but when you bring in sequestration, that brings us below cost. When you back out any unallowable costs, that brings us down further. And then the biggest factor with cost-based reimbursement right now is that it's based on historical cost. And so that needs to be updated to current to make our service lines sustainable. Again, focusing on really those core service lines. As statistics show, our rural populations typically are older, they're poorer, they're sicker, we know this, and that often brings us into spaces outside of healthcare, where we're trying to be part of the solution, working on how do we address transportation barriers to care, how do we focus on food insecurity programs within our facilities. As Raul alluded to, a lot of DHS members are here today. This isn't typically the wheelhouse of a hospital facility, but we find ourselves getting up further upstream to try to be more preventative in our approach. A little specifically, do you just want me to jump into my topic? Okay. A little bit specifically kind of on collaboration. I've been in healthcare for just coming up on 16 years. All of those 16 years have been at Lakewood, so I definitely have a rural slant, which I think is pretty important in Minnesota because of how rural we are. But some of the things that I've really learned over my career, I've been CEO for 2 years. Prior to that was Chief Financial Officer. But collaboration is key to success and key to independence. Initially, I thought that collaboration was really community focused. The stronger the community, the stronger the facility, and vice versa. Expanding that further to realize that really that collaboration is between nonprofits across the state. During COVID, we stress tested our system and we found how critical it was that we all collaborated together to make sure that those medical patients were in the right place to receive the right care. Right now, we're really seeing that on the behavioral health front. I know we all are familiar with borders and we hear about borders in the news, but I think the word border kind of dehumanizes the situation. My first day as CEO, we received a border in our ER. Each day I would go up and do my rounding around the facility and I'd ask the ER staff, have we found placement? Have we found placement? 120 days into my time as CEO, this border was still there. That story maybe isn't super impactful. I mean, it's a problem. But I think it gets to crisis level when I share with you all that border was a 12-year-old girl who had the cognitive ability of a 6 or 7-year-old. Her parents were absolutely at their wits' end, couldn't physically contain her anymore, couldn't keep her from hurting herself or them, so came to Lakewood. As a community provider, we are a district hospital as well. We have a commitment to take care of these patients, but we also have a commitment to give them the right level of care. That level of care is not happening in an 8x10 safe room or a cell within our ER for over 100 days. Thankfully, we are a small facility, and word travels that this patient is within our walls. Once her behaviors were assessed and once she was med managed, we did have a small group of individuals, including myself, that would go in on over lunch or at the end of the day and play Candyland with her. But, long story is that basically we need to find the right placement for these patients. So these gaps in care are not appropriate. It's stressful on our workforce. It's not what our physicians were trained to do. They're trained to get them to fix them or get them to the next level of care. Another story I'll share with you very briefly, because I know we're kind of running into time, is most recently we've had a boarder who was at our facility for 120 days. Again, a vulnerable individual in and out of the criminal justice system, in and out of the county system, in and out of our ER as well as our neighboring ERs. The reason I shared this story with you is I think there's a key point that shows our system is broken and proves we can do better. This individual was in the county jail for over 75 days, working with county social workers, the county medical team, everyone across the board to find placement into a CBHH or a group home. He was 2 days from being discharged to a group home, and he had an acute situation that was beyond what the jail staff could manage. So they appropriately brought him to Lakewood. At Lakewood, we had to file a Jarvis so we could get him medications, which is not something we typically do in our ER, to get him med managed. After 120 days and extensive resources on this patient, one-on-one, 24/7, he's registered, like I said, criminal background, violent behaviors. We finally were able to secure placement for this individual. Had that individual not moved from an inmate status to a patient status, he would have found placement 2 days prior to coming to us. But because the status changed within the system, he essentially lost his place in line and was moved to the back of the line. And all of those resources had to be redundant and put towards him again. And again, resources are one thing. I told you I'm a CFO background, so I hate waste, but the bigger issue is his time was spent without any programming, again, in an 8x10 safe room, and a serious gap in care where he can continue to decline. So I just think it's so important that we realize how important it is to work together, not only our nonprofit systems, but our county-based systems, our statewide systems. What is Lakewood doing internally? We've convened with groups, we've convened with our law enforcement to brainstorm how can we get upstream on this, how can we prevent that from happening. But I think what I would share with this room is, healthcare is an industry of unintended consequences. So there's a reason that status change triggered that. But what it actually plays out to be in operations is so impactful in a negative way. And so I think just opening the chain of communication or having that communication available, if there are decisions that are going to be made, reach out and ask, so here's what we're thinking. What does that look like? How does that play out? And how can we, I understand regulation, but we need to make mindful regulation. We need to make informed regulation. And so being here today, I really appreciate having the opportunity to network with you all. And hopefully we can learn to, again, network a little bit and make informed regulation.
Thank you, Lisa. You reminded me of my 5 years in Starbucks. I was, for most of those years, I was the only physician there with some locums. It was the smallest critical access hospital in the state of Minnesota, 2 hours and 17 minutes away west from the Twin Cities. And, the human part of the story, as Lisa pointed out, when there's a patient that could do better at a different facility, what that also impacts is our staff. We see workplace violence. We see, our nurses and our nursing assistants and others, being verbally and physically, unfortunately, put in bad situations. And we're working on that. We again appreciate the legislature, that wanted us to do more. Last year, 100% of the hospitals in the state of Minnesota are jointly working to improve workplace violence. But again, sometimes patients are dealing with difficult medical issues, psychological issues, and unfortunately, this plays out in our units. And so to add that human element, that's also very, very important. And I saw, what our staff was doing in Starbucks, the smallest critical access hospital. I saw the same thing and the same care being given at St. John's Hospital in Maplewood, a large hospital in the Twin Cities. So those patients that are unfortunately boarding or stuck in the hospital, sometimes you all see the Star Tribune News article about hospitals losing hundreds of millions of dollars, $500 million in 1 year because of these boarding or stuck patients. The human element of that is our nurses and our nursing assistants and our physicians are going out to the local, restaurant to buy food because that 12-year-old or that 17-year-old, we don't want them to get bored with the great hospital food that we provide. So there's a human element to all policy, and so I love what this conference says, bridging the gap. we need you all. So let's go now south to Winona with Rochelle.
All right, thank you, Rahul. Good morning, everybody. Thank you all for taking the time to come to this conference. I think this is awesome that we've got the mix of interested parties here in the same room to have like really critical discussions on what's going on across the state and the country, for that matter. I'm Rochelle Schultz. I'm the CEO of Winona Health, located down in Winona, right on the Mississippi River in southeast Minnesota. Beautiful little area. I, too, am an independent community health system similar to Lisa's. The difference is I'm what's known as a rural PPS hospital as opposed to a critical access. So my facility does not have cost-based reimbursement. We're reimbursed, basically off of fee schedules, and therein lies, certain problems for us. We do have a hospital. We also have senior services, so a long-term care facility. We also operate primary care and specialty care clinics. We have an ambulance service, pharmacy, and then some different kind of retail community-based services that we provide. Our service area is, Winona is the primary, Winona County. We have a couple of counties around us that don't have, hospitals, so we're considered a sole community provider. We cover a large geography, about 50,000 people that is our service area. Our referral centers are in Rochester and La Crosse, Wisconsin. I think as, I've looked at what's, happened kind of pre-COVID, post-COVID, and I think that's, there's a pretty dramatic change that I think all of us, have experienced. In the few minutes that I have, I'm to give you a very slight tutorial on the financing of healthcare, which is a kind of a mind-numbing experience. So I'm going to try to make this, pretty high level as to, what we deal with every day. So Rahul referenced a lot of reimbursement issues, as did Lisa. What it comes down to right now is I think we always try to find an equilibrium. As not-for-profit organizations, we're not out there to drive bottom lines. Our goal is to serve our community. It's to have a margin so that we can reinvest, so that we have the capital to buy the equipment that we need, to invest in our staff, all of those kinds of things. Today, kind of post-COVID, we've kind of gone over a cliff. So in 2023, for example, 2/3 of the hospitals and health systems in the state of Minnesota had negative operating margins. We were, doing okay maybe before COVID, but post-COVID, we're not. And we're all trying to evolve out of that, to make changes, to figure out how do we get sort of back on track, if you will. I think, in some areas, in some pockets, maybe that's, working a little bit better. We are not out of the woods, at this point. And so what does that look like? We've also seen, reduced capacity. That's the workforce issue. So, when we say we're full, sometimes it's because we're full because we only have the staff that we have. We may have not been able to operate, some units. We may have had to close some services, things like that, because we have to shore up the resources that we do have. I think where that shows up the most across the state is in the area of long-term care. We lost 30% of our long-term care beds in Winona specifically. I don't know that we'll get them back, in the future, because we don't have the workforce to do that. And it's fixing those pipelines to get the workforce, coming back in. The same thing is happening, I think in the hospital setting. Even as nurses are coming back, bedside nursing isn't the priority. People are saying, I don't want to work weekends, holidays, overnights, things like that, but our hospitals are 24/7, 365. So many of us are still using, agency staff, which are, a premium cost to get that covered and so forth. And so when we start looking at how do you get back on track, financially, we start looking at services. Okay, are there things that we're doing? What do we need to stop doing? What, whether we can look at where do we grow and find other types of things. There's very few services that actually make a margin. They're more procedural in the surgical area, which is why you see surgery centers and so forth, popping up. But taking that out of a hospital, hurts us. So one example of that in my organization was, when we look at those hospitals, I'm one of the hospitals that had the negative margin, and mine was a pretty ugly margin. I haven't seen that in my, 35 years of working in healthcare. I've been at Winona for 23. We've never had, a financial year like we did, last year. So, we're making progress, we're coming back. But when you have to look at services and think that you can't provide something, we did deep dives, and I'll tell you, those are really painful decisions. So the one that, we ended up looking at, I brought to my board and said, here's kind of a full analysis of this, was dialysis. So I have a dialysis program. I run the only 5-star dialysis program in our region. It's a great program. If you know anything about dialysis, that's a life-sustaining service. And it's painful to even put that out, on the table for discussion. In fact, my board said, as we went through the whole thing, well, what else is on the list? Is there something else we can look at? I said, there's nothing I'm going to bring to you that isn't going to feel painful and isn't going to hurt, because there's nothing that we're providing that isn't a need in our community. So I attempted to, get other regional providers, national, dialysis companies, somebody to take that program and keep it in my community. If we couldn't do it, maybe they could figure it out with scope and scale. And I couldn't get anybody to do that because they couldn't make it work financially. We were losing $1 million on just that program. So we made the decision. We were going to close dialysis, talked to our patients, went through the whole process. All of the staff, we had positions for people, things like that. So we kind of went through it, incredibly painful process. And I'll tell you, from Winona to La Crosse is 30 miles. For a dialysis patient to get transport, we do not have taxi services. We don't have Uber and Lyft. We don't have any of those kinds of things, in our area. For them to get a medical transport to go from Winona to La Crosse is $275. These people don't have $270. You have to do it 3 times a week, as you know. So they can't do it. So we're trying to, behind the scenes, figure out how can we get bus services, how can we combine things, how can we do, a lot of different services, because we had people moving out of our community to another community where there was family, or they could be closer to a bigger dialysis unit just because they couldn't afford, like the transportation. So this was really kind of a tough experience to go through. Now, as it turns out, it was really like at the 12th hour. We had everybody placed. We're kind of going through the process. We hadn't transitioned anybody at this point. And I did have a community donor who stepped up and said, him and his wife would give us $3 million to keep that dialysis program operating for 3 more years. And I'm like, thank you. And it took us a couple of weeks to organize, to put together, in a heartbeat. We went back and said, okay, we can keep the program. Every one of our patients, of course, stayed, and staff and so forth. But it's like out there hanging, what's going to happen in 3 years? I don't know what's going to happen in 3 years, but it gives me 3 more years, to figure out, some kind of a solution. And for us, it's not even about making money. It's about reducing what that loss is. But that's, the choice for people was like, move and figure out how you're going to do this, or go on hospice. That's the choice. So these are really painful decisions that, all of us in our, communities are having to make when we look at sort of this cost issue. Broadly, why are we sitting in this? Rahul mentioned a lot of this. It's demographics. So it's not that we're not busy. We have patients coming in, whether it's the ER, the hospitals, the clinics, and so forth, but our demographics are aging. So our mix of patients is heading more into that Medicare, Medicaid, the public payer realm, as opposed to commercial. When we look at enrollments, the fastest growing program right now is Medicare Advantage. The commercial is actually negative in terms of enrollments. So the workforce issue is really big from the standpoint of trying to balance this out. Medicare and Medicaid don't cover even cost. Okay, so in the state of Minnesota, Medicare, for example, underpays by about $1 billion. Medicaid underpays, and this is cost, not what we charge, but what it costs to take care of patients. Medicaid is short $837 million. So $1.8 billion of shortage has to be made up someplace, and that's just to break even on your cost. And so the whole financing, piece of it is, oh, well, we just cost shift that over. That's sort of this hidden tax on employers, if you will. It's why commercial insurance costs so much, because that has to offset, what is the underpayment, if you will, by the public side of things. So as we see more revenue, coming in, people on these, who have that payer mix that are more of the public programs, and our revenue is growing, we're actually discounting that off at higher and higher rates. So when you really get to the net of it, we actually have less revenue coming in with increasing costs on the expense side. When we talk about workforce, that's for all of us probably our number one cost. And our staff deserve everything that they're getting paid. This is hard work, and it's become a lot harder. We've got the labor, we've got the supplies, we look at pharma, all of those that are the inputs coming in. There's no place for us to pass on this cost because the government payers, Medicare, Medicaid again, Medicare Advantage, those are fixed. It doesn't matter what we charge. That's a fixed payment that we get, and there's no increase to those payments. So we can say our costs are going up, but if there's not an adjustment that's coming in for those payments, there's no place to pass on that cost. And that's where we're sitting is those costs are going up, inflation, you all know this, is going up, our inputs are going up. We have no place to pass on that cost. And so what happens is we're just getting deeper and deeper, into the red or going negative. So we're not in the financing model doesn't match anymore what the care delivery is, let alone all of the other issues. When we talk about people who are boarding in our ERs or our hospitals, there's no payment for them at all. So we're now taking care of more people because nobody else knows what to do with them. The way I sort of phrase this is, what's broken and fragmented in our communities is showing up on our doorstep in the ER typically, and then it flows through our system. So we have some really significant issues, hitting our entire ecosystem, if you will. In how we operate. So what are we're going to do about this? I look at ways that we can partner in our community. We have a mental health collaborative, for example, where I can pull in the county, the city, law enforcement. How do we share in these issues? How do we look at these as community issues and come together with all of the resources that we have in our community and work on solutions? We look at value-based programs with our payers. How can we start changing the care delivery? We can change the care delivery. We need the financing to line up with it. And those are some of the things that we're looking at and have a little bit of success doing. We just need to do it much bigger, much faster, because this is continuing to sort of march on. We need to, working with our state lawmakers around the Medicaid payment issue. We're on 2019 rates, as opposed to updating those for what has happened since 2019 from the cost side of things. So there's a lot of work out there to do, but at the end of the day, I would say across our entire state, our hospitals and our health systems, we're the safety nets for so many things that are happening in our communities right now. And it's going to take everybody, as Rahul said, agencies working together, across our communities, our lawmakers and so forth, to start figuring out like what's our path forward and how are we going to be sustainable into the future.
Thank you, Rochelle. So we'll hang out a little bit. If you have questions at the break, we're going to keep the conference moving along. So in the remaining 2 minutes, I'll just attempt to summarize what I heard from these three leaders who work 24/7. Some of the agencies that are in the room, it's your role to come and regulate us. So the Department of Health is on site, but the other agencies our doors are open. We are community-based organizations. Lawmakers, you already know this. If you want to come visit, all you have to do is make a call. We will give you a tour. If you want to come and talk to a patient that has been stuck in our hospital for a year, we'll make it happen. If you want to come and see what our nurses and our physicians and our nursing assistants are doing on a daily basis, half an hour of your time will show you what it is like on the front lines of healthcare right now. I think that there's an opportunity because in my advocacy role at the Hospital Association in the last 10 years, I have seen this happen. This is the state legislature 2 years ago where there was a bipartisan effort to have the very first mental health omnibus bill. The lawmakers agree on many things. That was a bill that got passed in the last few minutes of the session 2 years ago, and provided much needed funding for our mental health workforce, much needed resources. And as Lisa said, I loved what you said about smart regulation. We are an industry, if again I use that term hesitatingly, but we're an industry where our customers walk in and may not walk out alive. What other companies and industries can say that? So yes, my perception and position on this is we deserve to be regulated, but smart regulation is key. Having regulation that gets between our nurses and our physicians and our nursing assistants and the care they want to provide to their patients is not going to serve us. And then you heard about what is happening, what are the symptoms and the root causes. I think we can reclaim our status as one of the best states, if not the best state in the country, to provide and receive healthcare. I saw it in Starbucks, and if you want to hear the end of the Starbucks story, that hospital closed in 2005, so catch me at break. So that was a heartbreak, and I left that town, and I came to the Twin Cities. But let's not have that be our future. Let's make sure that our not-for-profit hospitals are thriving, are alive, are well, and agencies, you have the power to work with us, to help us, to support us. And lawmakers, of course, please continue to do what you have been doing for the last couple of years. Continue to make healthcare workforce a priority, loan forgiveness for our nurses, training our nursing assistants, training more physicians, mental health, but also some of the financial issues. The not-for-profit hospitals need all of you, because at the end of the day, what do we all care about as patients? We care about affordability, we care about access, and as a primary care physician at heart, that is my plea to you all. Thank you so much for your attention. Hopefully this was thought-provoking to you all, and we are only up into your break by 1 minute, so have a great break. We will hang around, catch us, and then see you through the rest of the day.